Hi, and welcome to the first journal club of the Global Society of Rare Genitourinary Tumors. And today we are going to discuss the article, A Global Approach to Improving Penile Cancer Care, published in Nat Rev Urology by members of the Global Society of Rare Genitourinary Tumors. I'm Laura Marandino. I'm a medical oncologist at San Raffaele Hospital in Italy, and it's really a pleasure to be here today with Dr. Philip Spiess from Moffitt Cancer Center, who is also the president of the Global Society of Rare GU Tumors. And we also have with us today Dr. Ben Ayres, who is a urological surgeon and an expert in penile cancer at St. George's University Hospital in London, and Dr. Marco Bandini, who is a urological surgeon at San Raffaele Hospital in Milan. So first of all, I would ask to Dr. Spiess to introduce us the Global Society of Rare Genitourinary Tumors.
Thanks again, Laura, for introducing me and as well the Global Society as part of this first journal club. As you all know, the Global Society of Rare GU Tumors really launched about 2 years ago to really address a huge unmet need, which was felt to be present within the cancer community, really highlighting, I think, where there's needs for improvement of education and science and research related to rare cancers, but also to really allow some areas of the world where they see a significant number of cancers such as this, but are underrepresented related to research and education. And I think this journal club we'll be discussing today is a perfect example related to what our society is ultimately wanting to accomplish in the coming months and years. And definitely want to congratulate Marco and the entire team for putting together what is felt to be a really critical article related to highlighting what our current state of knowledge is, but also understanding a little bit how differences exist throughout the world and how patients are managed. In terms of my disclosures, as mentioned, I do serve as the president of the Global Society, and I'm very privileged to have launched and conceived the society with my good friend Andrea Necchi several years ago. And I do serve as the vice chairman of the NCCN for bladder and penile cancer. So again, this came as a concept versus anything, and I know Marco was part of this initial conversation. We really felt that parts of the world who see a fair amount of cancers, such as penile cancer, unfortunately do not publish or often do not have opportunities to engage in global initiatives and research. And this definitely felt to be a great venue that we could help facilitate that. So the society formally launched back in July of 2020. We had our first leadership council in September 3rd of 2020. And I think it's been a whirlwind after that. We had our first global summit dedicated to penile and testicular cancer. And this was really a exceptional meeting where we had over 350 members and attendees who participated in this. And really, it really led to some really important, discussion related to what are the current clinical trials that are taking place? How do we engage colleagues and partners from parts of the world where there clearly is interest and see how we could sort of help facilitate their participation and their engagement, at the same time elevate level of education and care ultimately in some areas of the world where there ultimately is really sometimes a lack of evidence-based care which is applied to patient management. So you see again why the society is created is multifold. We know that clinical trials unfortunately underrepresent rare cancers like penile and testicular cancer. We clearly know from a funding standpoint, these are often underfunded. Guideline-wise, I think there's been a lot of efforts both in Europe and North America to develop guidelines, but consistency in guidelines is also something we're challenged with, and something which I think our society would like to help facilitate, really educating the global community related to these important guidelines that have been developed. We have a very strong and engaged pathology subcommittee because also similar to what we see in clinical care, in terms of pathological knowledge and diagnostic skill sets, there's a lot of heterogeneity and sometimes inconsistencies in parts of the world in terms of they don't see many of these cancers and not educated in terms of deciphering some rare entities. So clearly that committee and part of our society has been very fruitful and successful in doing that. So our mission really is several-fold, but it really is to advance the management of rare genetic tumors through a global collaboration of the scientific community. And I really do think the society is a perfect example how through efforts to gather thought leaders from many parts of the world, you're able to really accomplish many things in a very short period of time. And it's important to also understand that our focus is not only on the physician standpoint, but it's also on the patient advocacy standpoint. And I do want to recognize groups like ORCID and other such societies which have been working really tirelessly to elevate patient advocacy. But we want to serve as partners and as well as a conduit to facilitate that information being disseminated to patients around the world. So again, we do have a mission of education, patient advocacy, and science development. This is a perfect example of things we want to accomplish through journal clubs and discussion of meaningful research and initiatives. And I also think, as we'll be discussing today, there is underreporting of these rare cancers in many parts of the world. And in many areas of the world, we see and know that they see a significant number of such cancers. And we want to, again, allow these groups to participate in important studies, such as you see here on the right side, the IMPACT trial and other important international trials to elevate really level 1 evidence in patient management moving forward. In terms of cancer biology, I do think that we have a great opportunity here to use a lot of translational and bench work that's being developed and make it actionable in terms of developing novel new targets and systemic therapies for patients. And last but certainly not least, I do think that we want to serve as a conduit to facilitate important clinical trials being developed and also potentially being promoted through the global society. This is our infrastructure. There are many important team members. Several of the people on this call are critical to society and are really, I think, deserve a lot of recognition in what's been accomplished. And I do think the most important thing is I think that the future is very bright for our society through many initiatives that we're sorting to help facilitate and active participation with other societies. So it's really been very heartwarming to see how this society has been embraced by many groups to help, I think, elevate quality of care and education. Again, this is our Leadership Council group that's actively participating in these initiatives. And we have an education pathology research subcommittees as well. Many of our research now is also focusing in genomic type research and understanding some of the important novel targets that we need drug development related to some of these cancers. And again, we have a heavy social media group and participation through our Twitter website, our Facebook accounts, and really continual, I think, important promotion of important research that's taking place in rare cancers like in penile cancer. And I think that we are definitely planning our next global summit in the coming months, which will be dedicated to upper tract and rare variants of kidney cancer. Clearly, that isn't a critical area related to the society and what we'd like to advocate for and promote. And we'll talk a little bit about this as we sort of go through the journal club, but I do want to mention that the goals in penile cancer research are several-fold. Their education, their patient advocacy, and really this can really be a critical area of focus for our society in the coming months and years through patient surveys and physician surveys to know where they feel there's a critical need and where we need to sort of focus our education and research, particularly educational type research and initiatives. I think a global representation in terms of retrospective and prospective trials is something we critically need to do and promote, particular parts of South America, parts of India and Africa, and where we clearly see there's a significant number of penile cancer cases, for example, that occur, but unfortunately they're underrepresented in many of the studies that are taking place, particularly clinical trials. We clearly know if we can engage them in some innovative clinical trials, number of patients that could be accrued and meaningful questions we can answer could be done so in a very timely fashion as well. I think in terms of novel genomic signatures, we have a really wonderful group of our genomic subcommittee, which is engaged in looking at retrospective data. But I definitely think as we identify novel targets, the goal would be to develop really important potential systemic therapies which we could use, particularly in patients who fail first-line therapies, who unfortunately may not necessarily have any options available to them. And last but certainly not least, as we were discussing before, I think there are very few and far between clinical trials taking place in rare cancers. We clearly know, for example, penile cancer is often incorporated in basket trials just because it's incorporated with head and neck and other type of gynecological squamous cell tumors. But we know as well, although there are similarities, there are some differences and uniqueness to penile cancer that are critical to understand. So particular clinical trials focused predominantly on these areas are going to be critical for us to sort of focus in. And I'm definitely very proud and I think motivated that our society wants to take an active role in promoting and supporting that. And I would say even take a leading effort in doing that in the months to come. So thanks, Laura, for giving me a few minutes to talk about our society.
Thank you for the introduction. Now we can move to the article presentation by Marco Bandini, who is also the first author of the article. Please, Marco.
Thank you very much, Laura, for this introduction. I'm just sharing my slide. It is a great honor for me to give this talk to the first journal club for the Global Society of Rare Genitourinary Tumor. I'm going to present our very recent publication on behalf of the society. Here you can find the paper just published at the end of 2021 in Nat Rev Urol, a global approach to improving penile cancer care. It is very important to emphasize where this publication began and started. And it was the 11th of December 2020, during the first unbelievable and unforgettable meeting of the Global Society of Rare Genitourinary Tumor in 2 days, discussing two important topics about penile cancer and testicular cancer. I had the privilege to be one of the speakers of one of the numerous sessions of the meeting. And I was presenting with 5 other incredible authors about the global voice of penile cancer research and the international registry. So this session was about emphasizing the problem around penile cancer in terms of research and issues that were affecting in different ways many geographical areas around the world. So the presentation was organized like different experts were presenting the problematic around penile cancer clinical management and research from different geographical perspectives. So Professor Nicholas Watkin was discussing about European perspective, the Raj Master in North America, and especially United States, Yao Zhu for China, Gagan Prakash took over for India, Alejandro Rodriguez in South America, and Mgaga Ssebakumba for Africa perspective. So as you can find also in detail in the paper, in the first part, we focused about the discrepancy between penile cancer incidence and clinical research. As you can see from this map, the incidence and prevalence of penile cancer is very high and very heterogeneous around the world, with areas like South America, South Africa, India, and Pacific Asia, where this incidence is very high compared to the rest of the world. But on the other side, clinical research and research activity on penile cancer, according at least to first author publication, is, as you can see, on the opposite way, with developed country leading this ranking. This is not just for paper and publication, but is also for national registry enrolling patient with penile cancer and collecting data for it, but also, and most importantly, for clinical trial ongoing. So in detail, as you can read in the manuscript, from the European and North American perspective, what should be improved in penile cancer is definitely that because the incidence is very low, trial recruiting is difficult. So trial takes a lot of time to be completed, and sometimes they fail in terms of recruiting. There is still a lack of centralization in spite of some center, for example, in UK and also some North European country. It has been started a program of centralization, but many other countries, they don't follow any program of centralization. So what should be improved? Well, definitely to have governmental regulation that encourage centralization, focusing case in large center, which has more than 25 cases per year, should be a big start, and where to start to improve situation in this country. From the Chinese perspective, the researcher Yao Zhu emphasized the fact that in penile cancer, translational research is at the embryonal stage. We don't have many data, we don't have many studies. Initiatives are isolated. There is no large study or multi-institutional study. So here, definitely we need to improve because there has to be a connection between clinical and translational research. When moving to India, Professor Gagan Prakash emphasized that India is where the game should be played because India represents the country with the highest incidence of penile cancer, but still there is an extreme decentralization for treatment care, no compliance of guidelines, no recruiting trial, but India represents the real reservoir of this tumor. So it's very important to start changing also in this country, the situation, improving centralization, creating training programs. From a South American perspective, as you can see, penile cancer moves along with the HPV infection, which moves like a wildfire in this country and drives the etiology of the tumor. But understanding the HPV infection and also the demographic profile of patients developing penile cancer is very important. Also for starting large vaccination campaign, which can apparently and initially stop the spreading of the virus and the incidence of penile cancer. But before doing large vaccination campaign, we should understand better serotypes of the HPV serotype of HPV infection, which type of HPV infection are more common to make the vaccination campaign more effective. Last but not least, the situation of Africa, which represents an heterogeneous area where incidence of penile cancer goes from very low in northern countries like Egypt or Muslim countries to very high in the sub-Saharan part of Africa. Social and cultural and epidemiological factors are playing a huge role, as well as the interplay between the infection of HIV and HPV. There is a poor knowledge of the disease. Patients don't know what to do. They are shy to go to doctor and present the problem and start the treatment. On top of that, the number of urologists and physicians with the right knowledge and also armamentarium to treat this patient is very few. The ratio between urologist and inhabitant, it's 1 to 2 million sometimes of inhabitants compared to 1 to 15,000 of other developed countries. So there is a huge difficulties also for the physician to offer the treatment, to find and treat the patients. So we should start changing also these things with large educational campaign and supporting urologists also from this country in many different ways. From this unmet clinical need comes the call for the global society. As Professor Spiess presented at the beginning, the global society could facilitate recruiting for trials also from developing country, putting together experts, facilitating this collaboration, and also designing guidelines, creating collaborative collaboration medical society to promote penile cancer research and data sharing. I really thank you for this opportunity, all the members of the Global Society of Radiation and Tumor. It was a great pleasure to write this article on behalf of all the authors that helped me a lot, especially with the idea and material they provided for me. Thank you again.
Thank you very much, Marco, for your brilliant presentation. So you highlighted some important points, some unmet clinical needs, such as the need for collaboration and also centralization. And I would like to ask to Dr. Ben Ayres, as an expert in penile cancer, what is your experience, your point of view about these unmet clinical needs in penile cancer care?
Well, thank you, Laura. And before I answer that question, I'd just like to thank you for all your efforts you've put in to the Education Committee so far and to getting this first journal club off the ground. I'd also like to thank Marco and Phil for joining us this afternoon and Rachel for supporting us in the wings as well. I come in a very privileged position because I've only known penile cancer care within a centralized system. Penile cancer care was centralized in the UK around 2002, which was just after I graduated as a doctor. So when I started working as a urologist, we already were in the position of having centralization. Having seen what it's achieved, I think it has achieved many things, many good things. Some of the advantages are clearly multidisciplinary working within larger centres, bringing together expert oncologists, surgeons, pathologists, radiologists, specialist nurses, psychologists, and other support workers like lymphedema therapists as well, all in one space, in one institution to discuss and work out what is the best treatment for the patient. So multidisciplinary working clearly has been very enhanced by centralisation. Other really big advantages I think that it's brought in the UK is it really drove forward penile preserving surgery, and it allowed us to really push the boundaries of penile preserving surgery. 2 studies came out of the UK over the last 10, 15 years showing that the margins we needed to have clearance from the cancer got smaller and smaller. So at the start, people were talking around a 2 centimetre margin. A keynote paper came out of University College Hospital in London that maybe we could get down to a centimetre. And then we published our data a few years ago from St George's showing that if you had a 1 millimetre margin from the cancer, local recurrence rate was extremely low. So we've been able to push the boundaries of penile preserving surgery and bring in techniques like gland resurfacing for superficial and hyperkeratotic glands lesions. I think probably, though, the biggest thing that I think centralisation has brought in is around the proper staging of nodal disease. There's still a lot of evidence out there that not enough men with penile cancer are undergoing staging of their inguinal nodes. And we know that imaging is not sufficient in the vast majority of cases. Clearly in very low risk disease, G1, T1 disease, we know that tends not to spread. So those patients may be suitable for surveillance, but really everybody else should have their groins pathologically staged. We do that in the UK predominantly with dynamic sentinel lymph node sampling. I know that's not universal across the world, but again, I think the centralisation of penile cancer care in the UK really led to the development and the promotion of dynamic sentinel lymph node sampling. And just looking at our own data in St George's, we've seen a survival benefit since centralisation. So we know that our survival benefit is around the level of somewhere between 7 to 10% since centralisation over five-year survival. Now, it's an observation, so we can't say what really caused that, but I suspect it is down to pathological staging of our inguinal of our groins, and then appropriately treating the men early based on their nodal status. Clearly, there are some disadvantages to centralisation. Patients need to travel. The UK is a fairly small country, a fairly small island, so travelling around the UK is not as challenging as it may be in some other countries, but we still have patients that may be travelling for 3 hours to clinic and 3 hours home again. But clearly, technology has come on leaps and bounds in the last few years, and we do a lot of video consultations, and we also do outreach clinics. So I go out to some of the local hospitals that refer the patients into us and see patients for a whole county or state, in their local hospital where I can, to save all the travel into the centre. I think there still are many unmet needs, as have been mentioned so far. A lot of these are around patient unmet needs, and we're working a lot with our patient advocates in the global society and with other charities such as Orchid to try and drive these forward. But there are a lot of unmet needs, particularly around preparing the patients for, I think, some of the psychological impact of their surgery and consequences of their surgery, and also around lymphedema. I think those are the two big areas. By centralising care in the UK, we have been able to develop some psychological support for our patients, but I'm afraid to say it's not uniform across the whole of the UK. So even within a centralised healthcare system, we are not providing perhaps the best that we could for our patients. So there's still a lot of work to be done. Collaborating with other units will really drive the ways that we can tackle these patient unmet needs. And finally, collaboration is key for research. With such a rare cancer, we all need to come together and work together to share our data and to recruit patients into registries and into trials to really help understand the best treatments and best management for patients. But thank you again for hosting a wonderful session today, and thank you for inviting me along.
Thank you, Ben. So a final question for Dr. Spiess. Would you like to summarize the goals of the Global Society in order to improve penile cancer research and treatment?
Thanks, Laura. I think Marco's presentation really set the stage in terms of really identifying clearly where we currently state. And I think as Ben mentioned, there are clearly some very significant success stories and benchmarks that have been established in many parts of the world. And I definitely give a lot of recognition to our colleagues in the UK in centralizing care. As we sort of discussed, that's challenging in many parts of the world. So I think first and foremost, the goal of this global society is to really reach out to many leaders across the world who are dedicated in the care of patients with penile cancer, to allow them to have a voice, to allow us to identify where they feel the greatest needs are, to educate best we can their healthcare team members and patients, because many parts of the world, they don't have educational resources available to them. That could be just because of the language barriers that there may be. So I think working within our network of leaders within those areas, our first and foremost initiative is going to be, from a research as much as an education standpoint, is developing those materials and those resources so that they're readily available. And we've done a few surveys to know really where those needs are. Several of these are going to be things we're going to be publishing in the next several months. But I would say that's number one, is we clearly need to understand where are the greatest challenges and how we can fill that gap. Number two, I think all of us have participated in retrospective studies in penile cancer, but we acknowledge, gathering centers across the world that see a lot of penile cancer probably does not always necessarily represent real world. What Ben does at his institution, or what I do, or what Marco does at your institution are clearly at a very high benchmark of very high evidence-based, very early treatment, if need be, of nodal disease. As was mentioned, that's probably the strongest predictor of how patients are going to do. And in patients with advanced disease, looking at clinical trials, innovative clinical trials, in many parts of the world, they don't have access to those. No question, I think one lesson learned I've seen across the US is there is still a very significant underutilization of penile sparing treatments. Many times patients unfortunately undergo very severely mutilating surgery, and potentially that was not necessarily the only option. And an equally effective oncological but penile sparing surgical approach or non-surgical approach could have been considered. So I think our goal is to focus on retrospective, prospective studies, but also allowing, again, leaders from many parts of the world that want to participate in studies to have that opportunity to do so through large databases, which Marco has helped facilitating, which are going to be launched through the Global Society and other collaborators with other major societies. And I think what we'd like to also do is really work as a global representation for patients with penile cancer who are interested in participating in clinical trials, and help them sort of link to various important trials that are taking place across the world. One of the discussion points is, could we potentially run clinical trials through the Global Society of Rare G Tumors? And obviously there are some logistical elements related to that, which we're working through to see the feasibility of how that's done. But I think equally effective, as we clearly know, centralizing clinical trials and facilitating patients potentially across the world that want to participate has huge advantages. And I think those are definitely things we would like to pursue. And last but certainly not least, I think our genomics and personalized oncology group is really interested in trying to really use very sophisticated personalized genomic profiling of tumors to help identify novel targets which have not been, unfortunately, available in terms of new systemic treatments. But I do think this is very exciting because some of the challenges we've had with personalized oncology, as we all know, is centralization, getting sufficient number of cases, high quality cases, and having really a very centralized and consistent way in how these tissues are looked at. So I think that's also a wonderful opportunity, and we're very proud that Foundation Medicine, for example, wants to partner with us in several of these initiatives with Dr. Jeff Ross and other leaders from that group. And wonderful, I think, opportunities also to do more research in terms of identifying really the needs of our patients. I think, quality of life is something which is so poorly understood and studied in penile cancer. I remember writing a review on this several years ago, and the positive data on this area and true even potential people dedicated from the psychosexual efforts and effects of this cancer is really understudied. And I think we want to be a way of identifying, highlighting the important quality of life issues using standardized questionnaires, but also elevating ways where we can improve our patient outcomes. I think those are going to be critical as well.
So thank you very much. And it seems that there's a lot of work to do for the Global Society. So I thank you all for being here. I hope you enjoyed the first Journal Club of the Global Society. So bye.